Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host, Yaser, and today we're talking about something that looks deceptively simple until suddenly it isn't blood transfusion. And joining me is Ayham, the man who somehow manages to make immunohematology feel like a walk in the park.
Honestly, transfusion medicine is one of those topics where you can act confident. But the minute a patient starts reacting, you realize how important the basics are.
Let's begin like you're actually on call. A 27-year-old trauma patient rolls in, pale, hypotensive, and clearly losing blood fast. The surgical team calls out, hang 2 units of blood. You grab the bag, rush to the bedside, spike the unit. And this is where I want to pause. Ayham, before a single drop enters this patient's vein, what unknown world is already working in the background?
A whole world, honestly. People imagine the blood bank as a fridge full of bags, but it's really more like a microscopic ICU dedicated to blood alone. They screen donors, separate components, check for infections, do compatibility testing, store everything under strict conditions, and document every step. They are the reason we can even consider giving blood safely. And yes, they do all this while probably listening to Taylor Swift.
Now, before any of this reaches the blood bank, someone actually has to donate. So, what are the rules for donors?
Okay, so let's break it down. For whole blood donors, the age must be between 18 and 65. They can donate every 2 months, so 4 times per year.
And platelet donors are a different story, right?
Very different. Platelet apheresis donors, up to 24 donations per year, and a maximum of 2 per week, and can donate as frequently as every 48 hours. These folks are basically the superheroes of blood donation. Seriously, where's their cape?
That's a lot more frequent than whole blood.
Exactly, because with apheresis, we give the donor their RBCs back. We are only taking platelets. To donate safely, donors must also meet these criteria. They should have a blood pressure of 100 to 180 systolic over 70 to 100 diastolic, and a heart rate of 50 to 100, and their hemoglobin should be at least 12.5 grams per deciliter.
So, even the donor needs to be healthy enough to give healthy blood.
Exactly. Safety starts with the donor long before it reaches the patient.
And this makes me want to ask we say safe blood, but what does that mean in reality? Is blood ever truly safe?
For a short answer, it's not 100% safe. For the long answer, not 100%, but as close as possible. We screen for hepatitis, HIV, syphilis, malaria. We look for unexpected antibodies. We control storage. But when do periods exist? Rare antibodies exist. So the safest transfusion will always be the one the patient truly needs, not one we give automatically.
And this brings me to the next question. How do we know a patient actually needs it? Because the trauma patient clearly does. But what about the stable post op patient with a hemoglobin of 7.8?
Numbers guide you, but they don't decide for you. So, the real questions are: is the patient symptomatic? Are they hemodynamically stable? Is there active bleeding? Do they have heart or lung disease limiting oxygen delivery? Transfusion is a clinical decision, not a numerical reflex.
Tamam, let me ask the question students never actually ask out loud. When someone donates a bag of blood, what exactly do we get from it? Because we don't just give that whole bag to a patient anymore, right?
Yes, in modern transfusion medicine, we divide everything into blood components and blood products, and they are not the same thing.
All right, let's pause for a moment. Start with blood components. What counts as a component?
Blood components are what we obtain directly from separating a single whole blood donation. The big four are: 1. Backed RBCs for oxygen delivery, 2. Platelets for bleeding, 3. Plasma for clotting factors, 4. Cryoprecipitates for fibrinogen, von Willebrand factor, and factor number 8. These come straight from the donor's unit. It's basically the Avengers of blood, each with a special power and a very strict dress code.
Got it. Straight from the bag, just separated into parts. Platelets themselves come in different forms, right? I always hear about random donor platelets versus apheresis platelets.
Perfect place to talk about apheresis, because it's actually a method of collecting certain components, especially platelets. We extract a specific blood component and give the rest back immediately. It's like ordering only the part you want and returning the rest. There are two types. The first one is going to be the donor apheresis. Here, we take components from a healthy donor. We can collect three things. The first one is going to be the platelets. The second is going to be the leukocytes, which is very rare to collect. The third one is going to be the plasma. Apheresis platelets are especially valuable. They come from one donor instead of five random donors.
So, it reduces exposure and lowers alloimmunization risk.
Exactly. And the second type is going to be the therapeutic apheresis. This is when the patient is connected to the machine. We remove harmful things like pathologic antibodies, like myasthenia, excess cells, like leukostasis, and abnormal plasma components, and we return the cleaned blood back.
So, donor apheresis helps us collect components, and therapeutic apheresis helps treat disease.
Yup, you got it.
Okay, so now let's zoom in on platelets. What are the forms we actually use?
We basically have two big categories of platelet concentrates. The first one is the random donor platelets from whole blood. The second is the apheresis platelets from a single donor. Random donor platelets can be prepared as platelet rich plasma platelets, buffy coat platelets, and pooled platelets, which is a combination of 4 to 6 donors.
Yani, if pooled platelets come from many donors, that increases exposure risk, right?
Exactly. More donors mean that we're going to have a higher alloimmunization risk.
And apheresis platelets?
Apheresis can collect a full therapeutic dose from one donor instead of 5 to 6, so a single apheresis donation replaces multiple random donor units. We use apheresis platelets specifically for alloimmunized patients, patients who should avoid exposure to too many donors, when large platelet doses are needed, when lower leukocyte contamination is required, and lastly, to reduce HLA alloimmunization.
So they're cleaner, safer, and best for patients needing repeated transfusions?
Exactly.
So that covers components and how we collect them. Now, what about blood products?
Blood products are things processed, concentrated, or purified from plasma. These are the four refined versions: albumin, IV immunoglobulins, factor concentrates, factor 8 and factor 9, prothrombin complex concentrate, which is also known as PCC. Basically, the blood went to college, got a PhD, and came back all refined and smart.
So components equals separated and product equals manufactured.
Exactly. And the rule is give the patient exactly what they need, nothing extra.
Now that we know what we're giving, here's something students always mix up. How should each blood component be stored? Why is it that some go in the fridge, some stay warm, and some need freezing?
Because every component has its own personality and its own preferred environment.
All right, walk us through them like we're taking a walk through the blood bank.
Let's start with the basics. Firstly, RBCs and whole blood. They love the cold. We store them at 4 to 8 degrees Celsius. And depending on the preservative solution, CPD gives 35 days of shelf life. SAG-M extends it to 42 days.
So these stay chilled. Well, makes sense to me.
Next comes FFP, which stands for fresh frozen plasma. This one is extremely temperature sensitive. But how do we store FFP? If it's negative 40 degrees Celsius, we can store it up to 24 months. If it's between negative 30 and negative 40 degrees Celsius, we can store it for 12 months. If it's between negative 25 to negative 30 degrees Celsius, we can store it for 6 months. And if it's between negative 18 to negative 25 degrees Celsius, we can store it for 3 months. Basically, the colder you store it, the longer it lives.
And platelets are the weird ones, right? They're the only component that prefers room temperature.
Exactly. And that's because cold temperatures activate and destroy them. They are stored at a temperature between 21 to 22 degrees Celsius, must be continuously agitated, and they only last 5 days,
5 days only? That's shorter than a carton of milk.
pretty much, which is why platelet shortages are so common.
Okay, so that brings me to another question. Do we ever give whole blood anymore?
It's rare, but it absolutely has its place. And the first scenario would be when there is a massive bleeding or shock. The whole blood gives everything at once: volume, RBCs, platelets, and clotting factors. So it's perfect for massive trauma, operating room hemorrhage, or shock from acute blood loss. And the second scenario would be for exchange transfusion in newborns used in severe hyperbilirubinemia or hemolytic disease of the newborn because the entire blood volume is replaced at once.
So, whole blood is for when the system needs a full reset. Like when you reset your laptop after a very long day of work.
Yep, that's right.
طيب أيهم. So after the blood is collected, separated, labeled, typed, screened, matched, all that yada yada. Is that it? Are we done?
Not quite. There is a whole set of post testing safety steps before the blood ever reaches the ward. Think of it as the final checkpoints.
What kind of checkpoints?
First, leukoreduction, removing white blood cells. Then, irradiation if the patient needs it. Then we keep the blood in proper storage at the blood bank. Confirm the labeling, issue it correctly, and make sure it's transferred under the right temperatures. If any of these steps fail, the transfusion becomes unsafe.
I don't want to call out the elephant in the room, but why do we remove leukocytes? They're not the enemy, right?
Leukocytes are little troublemakers in transfusion medicine. We remove them because they can cause alloimmunization against donor WBCs and platelets. Also, they can cause CMV transmission, and they might also cause febrile non-hemolytic transfusion reaction. And lastly, they can cause immunomodulation that increases infection risk post-transfusion. So, leukoreduction makes transfusions cleaner, safer, and more tolerable.
And who actually needs leukoreduced blood?
Honestly, everyone. Most countries follow universal leukodepletion, meaning all blood products are leukoreduced before they ever reach the hospital. Because historically, certain groups needed it more, like thalassemia, leukemia, immune deficiencies, platelet dysfunction, and neonates. But we no longer wait for specific indications. It's just safer for everyone. Yes, everyone. Even your grandma's cat would get leukoreduced blood if it could.
Alrighty, now that you mentioned irradiation, why are we shining radiation on blood bags?
Great question. We irradiate blood to prevent TAGVHD, which stands for transfusion associated graft versus host disease. The radiation inactivates donor lymphocytes so they cannot attack the recipient's tissue.
And who needs irradiated blood?
Patients with weak or immature immune systems, including fetal and neonatal transfusions, immune deficiencies, allogenic bone marrow or stem cell transplant, hematologic malignancies, aplastic anemia, some solid tumors, and lastly, AIDS. If the immune system cannot destroy donor lymphocytes, radiation keeps the transfusion safe.
What about speed? How fast are we supposed to transfuse the blood?
There are simple rules. First, you need to go slow for the first 5 to 10 minutes. Then, adjust the speed based on patient tolerance. The whole transfusion must be finished within 4 hours. For children with cardiac issues, we keep it for 1 to 3 milliliters per minute because after 4 hours, the warm blood unit becomes a bacterial playground.
So now I'm thinking, if we're giving a specific component, How do we make sure that component will actually get along with the patient's immune system like best buds first day?
That's where cross-matching comes in. The blood bank basically plays matchmaker. They check the patient's ABO and Rh type. They screen for antibodies, and then they literally mix donor cells with the patient's serum to see if they fight. If they react, you don't give that blood. If they don't, you're good to go.
And if you accidentally give blood that does fight, something very bad happens. Ayham, there's this one test I keep hearing about in transfusion medicine, the Coombs test. What is it and why is it everywhere?
It's the backbone of immunohematology. It tells us whether antibodies are attacking RBCs. There are two kinds, and they answer two totally different questions. The first one is the direct Coombs test, or DAT, which asks, are antibodies already stuck on the patient's RBCs right now? If yes, that will lead to agglutination. DAT diagnoses: 1. Acute hemolytic reactions. 2. Delayed hemolytic reactions. 3. Autoimmune hemolytic anemia. 4. HDN, which stands for hemolytic disease of the newborn.
So, DAT equals, is hemolysis happening now?
Exactly. On the other hand, indirect Coombs test IAT asks, are there antibodies floating in the patient's serum that might attack donor RBCs? And it's used for 1. Antibody screening, 2. Antibody identification, 3. Cross matching, 4. Prenatal testing.
So, IAT basically means, will this blood relationship end badly?
Exactly. It predicts danger before transfusion.
Okay, so now we understand how compatibility works. طيب, what if something slips through? What would be the first reaction we would see?
Let us return to our trauma patient. 5 minutes into the transfusion, he spikes a fever, starts shaking, gets back pain, and his blood pressure drops. That's the nightmare scenario. Acute hemolytic transfusion reaction. The patient's antibodies destroy donor RBCs inside the bloodstream, usually because of an ABO mismatch. Symptoms hit fast, like fever, chills, back pain, dark urine, and shock. And the response is immediate. Stop the transfusion, run saline, support blood pressure, call for help. No hesitation.
But sometimes a patient gets a fever during a transfusion and they're otherwise stable. What's the gentler explanation here?
Hmm. That's FNHTR, which stands for febrile non-hemolytic transfusion reaction. Cytokines from donor WBCs cause irritation, not hemolysis. Uncomfortable, not dangerous. You stop the transfusion initially, rule out hemolysis, then treat with antipyretics. Leukoreduction helps to prevent this. It's like your annoying neighbor knocking on the wall. Irritating, but not life-threatening.
What if, instead of fever, the patient suddenly complains of itching? Maybe has a few hives?
Then it's likely a minor allergic reaction. Stop, give antihistamine, and if symptoms resolve, you can continue. These reactions come from antibodies against donor plasma proteins.
Now, let's take that same idea. But imagine the patient becomes wheezy and hypotensive instead of itchy. What are we thinking?
That's anaphylaxis, a true type 1 hypersensitivity reaction. Stop transfusion, give IM epinephrine, secure the airway if needed, manage like classic anaphylaxis, and next time, they may need washed RBCs.
Okay, Aham. What if a patient suddenly becomes very short of breath, hypoxic, and looks like acute respiratory distress syndrome?
That's TRALI, which stands for transfusion related acute lung injury. Donor antibodies activate the patient's neutrophils, leading to massive inflammation, which would end up with an acute lung injury. So, stop transfusion, provide respiratory support, often high flow or intubation, and no, diuretics don't help. This isn't fluid overload.
And how do we differentiate trolley from taco clinically? I know you might be thinking of the food, however, it actually stands for transfusion associated circulatory overload.
Great point. TACO has hypertension, raised JVP, signs of volume overload, and it improves with diuretics. Whereas TRALI has normal or low blood pressure, no JVP elevation, non-cardiogenic pulmonary edema, and lastly, there won't be an improvement with diuretics.
What if, instead of immediate reactions, the patient returns days or weeks later with jaundice and anemia?
That's delayed hemolytic transfusion reaction. The immune system remembers old antibodies and destroys donor cells slowly, usually mild but important to document. It's blood playing revenge, but in slow motion.
What about a patient who returns 5 to 10 days later after transfusion covered in petechiae?
That's post transfusion purpura. Their immune system destroys both donor and their own platelets. Treatment is IV immunoglobulins. This one you don't mess with.
Alright, before we quiz you, super quick recap.
We talked about who can donate and how often, then what makes blood safe, and when to transfuse. We also talked about blood components, products, apheresis, and whole blood. Then we talked about storage and post-testing steps, which are leukoreduction and irradiation. Next, we talked about compatibility and the Coombs test. And lastly, the major transfusion reactions like acute hemolysis, FNHTR, allergic, anaphylaxis, TRALI, delayed hemolysis, and BTB.
Now, let's see what you remember. Alright, listeners, time for your mini quiz. Think about each question for a second before Ayham answers. And the first question: a patient develops fever and chills 10 minutes after transfusion. Stable vitals, no back pain or hypotension. What's the most likely reaction? Is it A, acute hemolysis, B, TRALI, C, FNHTR, or is it D, anaphylaxis?
Correct, listeners. The answer is C, FNHTR. Sudden fever plus stability equals cytokine reaction.
The second question: a patient becomes severely hypoxic 30 minutes into a transfusion. Diffuse infiltrates on chest x ray. Blood pressure normal, no wheezing. Is it A, anaphylaxis, B, taco, C, TRALI, or is it D, a minor allergic reaction?
This is C, TRALI. This is the classic presentation of acute lung injury with no allergy signs.
So today, we didn't just talk about blood banking. We didn't just talk about transfusion reactions. We walked through them together, like family, the way they actually show up in real clinical practice.
From the blood bank to the bedside, everything matters. And when something starts going wrong, recognizing the reaction early can save a life.
Thanks so much for listening. See you in the next episode of PodBites, where medicine finally makes sense.
Hala, hala, hala.
hala.
And a hemoglobin rate of at least 12.5 grams per deciliter.
ما في hemoglobin rate يا حبيبي.
Platelet-rich plasma platelets, buffy coat platelets, and blah, 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 blah. حطوني في الحيطة في الحيطة.
استغفر الله.
And lastly, the prothrombin complex concentrate, which is also known as BCC.
PCC.
BCC شو حكيت؟
B.
PCC.
شو انك سوري يا حبيبي.